Greetings, I'm Jim Shea with the Acoustic Neuroma Association, and I'd like to welcome everyone to the ANAwareness Week and our presentation of decision-making surrounding small and medium-sized vestibular schwannomas, including impact on quality of life, with the team from Mayo Clinic. Dr. Michael Link and Dr. Matthew Carlson will introduce themselves in just a moment. First, I'd like to handle a few quick items. Captions are available for this presentation. You can turn those on at the bottom of your screen. Also, a reminder to keep an eye on our social media, particularly as this is ANAwareness Week, for all those informative posts on Facebook, Instagram, and even LinkedIn. It's a terrific way to learn about all the resources we have available and how you can be more involved with the ANA. As we always say, we're here to help, so we hope you will access those opportunities. And now, doctors, if you'd like to introduce yourselves, we can get started.
Hi, everybody. My name is Dr. Michael Link. I'm a professor of neurosurgery here at the Mayo Clinic.
My name is Matt Carlson. I'm one of the ear surgeons here at the Mayo Clinic. We're very grateful for the opportunity to talk to you about something we're very passionate about. There's a couple of things that we think about all the time, even when we're going to sleep and waking up, and one of those things is vestibular schwannomas. And within that topic, the management of a small to medium-sized tumor is really the heart of the conversation that requires a lot more discussion, a lot more data, and has a lot more nuance. And so we're super excited to talk to you about that today. And in that, we're going to weave in and out some of the data that we've collected through the ANA, which is largely, comprised of you, the viewership here that's watching and participating. And so, first and foremost, thank you for contributing to that. You're helping yourself, but also a very large group of people with decision making down the road by contributing to these things. And so, we're very grateful for that. And so it will be fun to kind of go through some of that data as well. We'll bring up the slides. We just have a couple kind of visual aids that we're going to use to present some of the data, but a lot of this is just going to be a discussion. Should work. Jim, what do you see there for a?
I see two MRIs, 32-year-old man with right-sided deafness.
Good. So it looks like it's in a presentation, or you just see the regular slide.
It's in the presentation, yes. All right.
So sometimes the decision making is not difficult or controversial. For instance, this is a 32-year-old man that we saw who had become deaf in his right ear, had facial numbness and some facial weakness, and severe ataxia, meaning he was very off balance. And he has an extremely large, formidable looking tumor. And I don't think there's any question that everyone would agree this patient needs an operation, and relatively urgently, which is really rare for a vestibular schwannoma. And as opposed to this woman, so this is an elderly woman who got admitted to our hospital with an episode of confusion, and they did an MRI scan looking for possible stroke and found a tiny little tumor here, and you can see she's got hardly any hearing loss in that ear. And once again, I don't think it's controversial. I think everybody would agree no treatment would be best. There's no reason to subject this woman to any risk of either surgery or radiation. But it gets more complicated in a situation like this, in a situation I suspect that most of you are in that the tumor isn't giant, it isn't tiny, it's somewhat symptomatic. So what do we do about that? And that's kind of what we're going to talk about, again, based on some of the things you have told us over the years. And I'll just give you 3 examples of how we manage these tumors. So the first patient is a 67-year-old woman who we have followed for 8 years now. And you can see, comparing at diagnosis and 8 years later, the tumor looks very stable. Maybe it even spontaneously got a little bit smaller. Her hearing declined just a little bit. The second patient is a patient I treated with Gamma Knife, and then 5 years later, the tumor's smaller. Again, the hearing declined just a little bit. And this is a patient we saw who originally is from South Sudan. Now he lives in South Dakota. And he was discovered to have this tumor, and we took it out, and he still has normal facial nerve function, and we saved his hearing. And so you might say, well, that's 3 great examples of successful decision-making and treatment outcome. But there's more to the story, as there often is. So for instance, that first patient has very bad disequilibrium and has almost become housebound because of dizziness. The second patient that I treated with radiosurgery has terrible tinnitus, and it's really become disabling, can't concentrate, difficulty sleeping. And the young man from South Sudan, his tumor was discovered because he had headaches. We took his tumor out, not surprisingly to us, he still has headaches. So actually 3 technical successes, but really 3 unhappy patients. So what Dr. Carlson's going to talk to you about is how we use quality of life data, the things that you talk to us about, to try and figure out when we see a patient with a tumor like this, how do we decide between just observation, radiation, or surgery to get to that magical intersection of happiness and success.
So, whenever we see a patient who comes in with there's a couple of contextual things I think are really helpful to go through. But right now, the average person, and there's a lot of variation, but the average person who comes in with a tumor is between the ages of about 45 and 70. And the average, in that number is increasing over time. So technically, the average age is about over 60. And the average tumor size is actually significantly decreased over time, and more patients have less symptoms from their tumor, meaning their hearing is better and they have less other contributing symptoms. And so you have this treatment dilemma where more people are being diagnosed, but with less symptoms. And if we keep treating people the same way we always have before, it probably leads to a significant amount of overtreatment. And so it's really dialing this in and finding the best individual treatment for each person, what they're trying to get out of it. The most critical thing to think about is some of the stuff we're going to say doesn't apply to everybody. We're really looking at the group that are eligible for the 3 different treatment types. So the first fork in the road when a person comes in with a tumor, in general, is tumor size. And so when we're talking about small and medium-sized tumors, so importantly, these are just general cut points, rules of thumb, and not, you wouldn't use them as strict cut points. But when we talk about small tumors, we're talking about a tumor that's either completely in the internal auditory canal or is just coming out a little bit, and generally less than 1 centimeter or 1.5 centimeters going into the CPA, we call that. So it's under 1 inch in size, in diameter. The medium size group is generally between about 1.5 and 2.5 centimeters in the angle. So that also is just under 1 inch. 1 inch is 2.54 centimeters. So you're just under 1 inch for the small, medium-sized tumors. Then the larger tumors, usually those over about 2.5 centimeters in the angle, so not counting the internal auditory canal part, are what we call larger tumors. And of course, you can have giant tumors and stuff. But really, if your tumor's under 1.5 centimeters, most people say you're completely eligible for all 3 management options: microsurgery, observation, or radiosurgery. If you're that medium group, we usually don't recommend observing it for a period of time, although it's not crazy. It's not a recommendation. Generally, if you're over 1.5, usually recommend radiosurgery or surgery. And then over 2.5 centimeters, we usually recommend surgery in most cases. Rules of thumb, not perfectly applied to everybody. But in the context of all we're discussing, we're primarily focusing on the people with smaller tumors or medium-sized tumors. So originally, quality of life data has become more important, just recognizing there's a lot more to the story, as Dr. Link talked about, than just us taking the whole tumor out or preserving the facial nerve. That's actually, if you're treated at a good center, being able to take the whole or treat the tumor with good tumor control and having a good facial nerve outcome is very common. So most centers for a small tumor, you're going to get that most of the time. And so that's not that you get that with most of them, but the other things that are less tangible, more difficult to study, can still really bother people quite a bit. And those are the things we talked about: tinnitus, dizziness, headache, and treatment regret. So like, what if you get a treatment and you went into it and you didn't get what you expected out of it? Now you have to live with it for a long time. And maybe it's because maybe you didn't have all the information you thought you needed at the beginning to make a good decision. That can really bother a person. But even if you had good information and you were in the minority of people that had an adverse outcome or whatever, treatment regret is also another thing. So originally there wasn't really a good measure. We would use something called the SF-36 or something like that. These are these really broad measures that ask questions like, can you carry groceries, and things that don't really apply to a patient with a vestibular schwannoma very well. In 2010, there was a disease-specific quality of life inventory that was developed, and that's important because that's a landmark in our journey of studying quality of life in vestibular schwannoma. The first time a disease-specific measure was introduced. As soon as that instrument was delivered, we were like, this is great. We finally have something we can use that's better, and we jumped on it pretty quick. It was developed by the Penn Group, and we used it from the beginning. Right when you first get a quality of life measure, you're not going to have good long-term prospective data because it takes a while to get that. So the first study most people do is they do a cross-sectional study. So they take a large group of people and they administer the survey to everybody, and you look at what people's scores are at that cross-sectional point. So that's what we did to start. We teamed with a group that we work a lot with in Bergen, Norway, and we studied in approximately 500 people. We looked at cross-sectionally, including some people without tumors, and we looked at quality of life measures. And we did to improve enrollment. We provided a very small remuneration or money back for people who contributed to it. And remarkably, we had about an 80% response rate overall, which is quite good for a survey. So in this initial cross-sectional group, in about approximately 500 people, we looked at the SF36 and the PROMIS 10 and the Glasgow benefit inventory. Those are not disease specific, but those are the legacy measures that we've used for a long time. So we still wanted to use them. We didn't want to throw them out yet. And we also looked at the Penn acoustic neuroma quality of life inventory. And then we looked at symptom specific inventory. So these are all what we call patient reported outcome measures. So we're not putting you in an MRI. We're not using a meter to test these symptoms. They're your reports about how these different conditions affect your well-being on a daily basis. So we looked at all these different things. And so in total, in 642 patients and 293 questions, we had basically about 250,000 data points, which is a lot of data points to parse through. The first thing so overall, the average person took the survey about 7.5 years following their diagnosis, if you were observed, or your treatment, if you had microsurgery or radiosurgery. And there were some small differences between the groups. We call that selection bias, which are inherent to all these sorts of non-prospective, non-randomized studies. That generally people who had received radiosurgery or observation were a little bit older than the people that received microsurgery. And on average, people who had microsurgery tended to have larger tumors and were younger overall. I don't know if you want to.
And so this slide, we're going to show you several of these charts where there's a column that goes through the radiosurgery group, that's SRS, the observation group, that's OBS, and the microsurgery group, that's MS. And then some pairwise comparisons. So radiosurgery versus observation, observation versus microsurgery. And these are all the objective outcomes. So these are the things we as doctors can measure either with the hearing test or by looking at a patient and saying, smile, close your eyes, or look at an MRI scan. And as Dr. Carlson just mentioned, there are differences because we all have biases in how we recommend treatment. And basically, this slide is just showing that patients who underwent radiosurgery had larger tumors compared to those who underwent observation. Even those who had microsurgery had larger tumors compared to radiosurgery, and the microsurgery group had larger tumors compared to observation. You can kind of see that here, that patients that had 2 to 3 centimeter tumors were more likely to get surgery, less so radiosurgery, and almost none of those were observed. But we can account for that. We can control for that when we do the statistics to look at, are there real differences? And once again, these are just the outcome measures that we can easily measure, that's reported in every paper that's written in the scientific literature about vestibular schwannoma outcomes. So this once again shows basically everybody starts with normal facial nerve function. It's rare as can be that a vestibular schwannoma causes facial weakness. And then these are the outcomes after treatment almost 8 years later. And once again, patients who undergo radiosurgery or nothing, their tumor is just observed, keep very good facial nerve function, but about 10% of patients who undergo surgery do develop some permanent facial weakness. And when you compare radiosurgery to when you compare microsurgery to radiosurgery or to observation, that is statistically significant, even though it's only about an 8 to 10% difference because we have a lot of patients in each group. Same thing with hearing. So again, this is almost 8 years after treatment. So patients who underwent radiosurgery, about 40% of patients who started with what we call useful hearing still had it. Almost 70% of patients who did nothing but observe their tumor still had useful hearing, and only 14% who had undergone surgery still had useful hearing almost 8 years. And so this is the results of the PAN-QOL, the disease-specific quality of life measure. And just to orient you, the blue bars are 103 normal people walking around the United States who don't have vestibular schwannomas, but were kind enough to fill out this very long survey that we sent them. And by the way, the PAN-QOL is only 26 questions. But when you add up everything else we asked people to fill out, it ended up to be 293 questions. The yellow bar is all the vestibular schwannoma patients lumped together, regardless of what treatment they had. So if you just want to say, what's the difference between, let's say, a normal person walking around the United States and somebody with a vestibular schwannoma, well, you can see on a scale of 0, which is the worst quality of life, and 100, which is the best quality of life, you know, most people walking around say, oh, they do pretty well. They score 90 on the balance subdomain, and all vestibular schwannoma patients are down around 68, so pretty big difference. When you want to look at it in more detail, the red bars are the ones that underwent radiation, the light green are the ones that were just observed, and the dark green bars are the ones that underwent microsurgery. And there are some differences, and when we statistically analyze that, there's even some statistical differences. So for instance, I showed you that basically, if you have radiosurgery or just observe your tumor, you're very much likely to only keep normal facial nerve function, but there's probably 10% risk to the facial nerve in all tumor sizes lumped together. And you can see this results in a statistically significant difference. And it is interesting also, even though we think patients have normal facial nerve function, still patients report some symptoms related to facial nerve function compared to normal controls, even though they probably had normal facial nerve function by objective measurement. Same thing for balance. The microsurgery group did a little bit worse. We know some patients suffer from headache. It turns out, though, when we looked at the data, patients who selected surgery as their treatment were more likely to have headache beforehand. And then the total scores do actually show a significant difference. So patients that did nothing reported a total score of 72. Patients who had radiosurgery had a score of 70, and patients who underwent microsurgery had a score of 65. And that was statistically different comparing microsurgery to the other two groups. And you can see people without tumors scored in the 80s. But there's another aspect to this story, and that is on a 100-point scale, how many point difference do you really need for the patient to notice that there's a difference? So for instance, if I tell you, well, because it's Friday, because it's a nice day out in Rochester, Minnesota, and because I get to talk to you all, my quality of life is 94 on a 100-point scale. But tomorrow, I've got to make rounds, mow the grass, it's going to rain, et cetera, et cetera. Maybe my quality of life is only 87. Is that really a difference? Is my quality of life really affected? And there are ways you can actually figure that out. And we wrote this paper that we published in one of the journals in 2019. And basically it shows for all these different scales on the PAN-QOL, sometimes you need a big difference in the numbers for it to be clinically meaningful for somebody to notice it. We did it a variety of different ways. But once again, these are the differences in the PAN-QOL total scores, 72 versus 70 versus 65. But for it really to be meaningful, it has to be 11 to 12 point difference. And none of these are within that range, the greatest difference is only 7. So although it was statistically significant, it's not clinically important difference.
So one of the questions is, what features, what symptoms or what conditions drive quality of life the most? Naturally, most people would say, well, hearing loss would be the most important thing because a lot of people, or most people with vestibular schwannomas get hearing loss. But remarkably, there are some things that are less commonly occurring, but if you have them, they're a bigger deal breaker for overall, daily quality of life. And it turns out that if you took a person who had each one of these symptoms, all of the symptoms, and you asked them to weight which symptom was the most bothersome or most disruptive to their daily well-being, it turns out that headache and dizziness, if you have them, can have a larger detrimental impact to your quality of life compared to hearing loss. Or another way to say it is, even though hearing loss is common, most people adjust to the deficits of hearing loss and can compensate reasonably well. Of course, it's not as good as having hearing in both ears, but your ability to compensate or adjust to it is greater than somebody who has severe headache and dizziness. And I can kind of naturally understand this myself. Like, imagine if I had just chronic head pain or that sort of thing, it would probably just naturally lead to more problems in your daily life than having hearing loss in one ear. So it's a little intuitive too, but so it turns out that the two main drivers are those two things. So what's interesting, those are two measures that we typically don't really look at or classically evaluate. We measure the things that are easy for us to measure and the things that we feel we have more control over. So things like hearing outcome, and facial nerve function, complete tumor removal. And we don't like to study the things that are more difficult to study and the things we have less control over, because it naturally it's frustrating from our end too, because we're trying to help people. It's hard to study these things, and particularly things like tinnitus, dizziness, and pain are difficult for us to manage effectively, or as well as we would hope we could for people who are suffering from them. So one of the things that is really remarkable, that really surprised us through this whole thing, is finding out that we have less ability to help or change a symptom from what a person comes in with than we thought we did. So there's this old adage in the surgical world that if a person comes in really dizzy, give them tumor resection and they're not going to be dizzy anymore, and life is going to be good for everybody. Or if you have bad headaches, then never get surgery, because surgery is going to make them then worse, and so you should have a non-surgical treatment, or maybe avoid a certain surgical approach or something. And the more we learn about everything, the more we realize that so many things that were kept, that we hold sacred or we believe as factual, really are not factual, and they were just passed on over time without any evidence to support them. And this is kind of those sorts of things. We've realized that what a person experiences before a treatment has the highest predictor of what they will continue to experience later. So if you have bad dizziness diagnosed before your treatment of your tumor, you have a higher chance of having ongoing dizziness afterwards. And the same thing goes for headache. That doesn't mean there's ways we can try to help effectively manage that, but it does help the patient understand and us understand what the outcome could be. Another way to say it is, we have another paper to show this, or a couple papers to show this, but basically, don't take a symptom you have and let that be the reason you choose a particular treatment, thinking that's going to be the way to escape that symptom. So, for example, if you have really bad tinnitus and you read a paper saying, this treatment is most likely to improve my tinnitus because my tinnitus is unbearable, that's probably not a productive way to go. Those are difficult symptoms to improve. There are exceptions to that. If you have a larger tumor and facial numbness, for example, removing the tumor can remove that symptom. Or if you have hemifacial pain, trigeminal neuralgia type pain, sometimes surgery has a higher chance of getting that symptom better. But in general, things like dizziness, tinnitus, and even headache, generalized headache and things, you shouldn't choose one treatment thinking that one is going to be the treatment that helps you escape or improve that symptom the best. And again, we're just talking about tumor treatment. We're not talking about ancillary treatments. We're not talking about like a cochlear implant to try to reduce tinnitus or those sorts of things, or balance therapy to remove balance. We're talking about the treatment of the tumor and how that has less impact. So if you take a group of people, just say you take 200 people, and you take them all before a treatment and you put them through a treatment and say their pre-treatment score was 70 overall. On a large scale, the average change a whole group of people had when they went through a treatment was 1 point on a 100-point scale, so, which blew our mind. We thought, of course, surgery or radiosurgery, or even just watching your tumor is going to significantly change your perception of your disease and the symptoms you're experiencing and how it's affecting you. On a population level, it changes almost nothing. And it doesn't mean individual people can't have big changes. So one person might have a big change before and after treatment, but on a population level, when you take 100 people or 1,000 people, the treatment itself, as long as it's done well or reasonably well by an experienced team, will have less impact on it than what you're actually coming into the condition with to begin with. So we talked about earlier that when an instrument first comes out, you can't have long-term prospective data because it takes a while to accumulate that. So even though we started using the PanQual very quickly after it was released in 2010, it took us a while to accumulate longitudinal prospective data. That means that a person takes the survey at the time of diagnosis, and then they take it 6 months or a year later, and then another year, and then maybe they get treatment at that point, and then you get after treatment quality of life, and you continue to follow them. So that would be prospective data. That's the short of being randomized, meaning you flip a coin deciding what treatment you get. But short of that our best data is prospective data, because you can get information on the individual people over time, particularly before treatment and after treatment. And so we looked at a large group of people comprised of members of the ANA that were willing to take the time to fill this out. And we looked at changes longitudinally over time among the different treatment groups. So this is one of the slides that we were alluding to earlier. If you take the total scores and you look at change in quality of life scores, so on this graphic, look at the bottom of the table, total. And that's the mean change before and after treatment. You can see that on a 100-point scale, the mean change was minus 1.1 for observation, or minus 0.1 for microsurgery, or minus 0.3 for radiosurgery. So almost no change at all. And when you look at individual changes, there was only a couple of things that really kind of came out. Like one of them was there's a small percentage of people who undertake surgery, not because they're trying to lose a symptom or prevent something, but because they want a cure, they want it removed. And for a group of people, there is a psychological benefit or quality of life benefit or perceptual benefit to having the tumor removed and having a cure and moving on. You might have some side effects from having the tumor before and having treatment, but you get your MRI the next time and it's gone. And so those people often gain benefit from surgery. But short of that, there really weren't any significant differences, which is really a very big surprising thing to us.
So, as Dr. Carlson said, that was very surprising. So we said, we got to drill down on this a little bit more. We got to come up with another way to look at this. And so one of the, we thought, straightforward ways to do it, particularly to look at some symptoms that, again, we can't measure with a test easily or an MRI scan, is just, again, to ask all of you, ask the patients, okay, just rate your symptoms from 0, no symptoms, to 10, the worst symptom you can imagine, looking at tinnitus, dizziness, headache, and how the hearing is. So those are things that we don't, we know that we don't fix with treatment, but badly affect a patient's quality of life. So this is just, again, a prospective study we did, almost 250 patients. You can see the breakdown in the number of patients in each group. And we said, okay, just tell us about your symptoms. And basically, once again, looking at tinnitus, dizziness, headache, and hearing loss on a scale of 1 to 10, first of all, you can see that for the most part, patients who elect observation tend to be less symptomatic. They use a lower number when they report their symptoms. And then this is almost 2 years later, and just like the other data suggested, there's not much of a change, other than most people report that their hearing gets worse with treatment or with time. But otherwise, very little change in these numbers comparing before and after, before and after. And this, again, is just the mean change at about 2 years. And the only thing that's significant is that we do know either with doing nothing or with treatment, hearing does tend to get worse in the treated ear. So, as Dr. Carlson said, if somebody shows up and says, I have bad tinnitus or I'm really dizzy, can that help us decide what to do for treatment? And I think the answer is definitely no. There are ways we can help patients with dizziness and tinnitus, but taking the tumor out or radiating it isn't the best first way to address that symptom. And so another question we had, probably the most basic question, we just started to ask patients, are you happy with what you decided to do? Or in retrospect, do you wish you would have chosen a different treatment? So a very binary question, yes or no. And once again, a large number of patients, mostly accumulated through the Acoustic Neuroma Association. Some of them had very long follow-up. Some of them were newly diagnosed. And when we asked this simple question, are you satisfied? So patients who underwent microsurgery, about 85% said, yes, I'm glad I chose that. Radiosurgery, 86%, essentially the same. There was only 10 patients in the group that had had both radiosurgery and microsurgery. So I think that's not enough numbers to be confident about those results. But of the patients who underwent just observation, 96% said, yes, I'm very happy just not doing anything, but knowing I have a tumor and it's under observation. And there are two ways you can enter treatment. You can either get diagnosed and say, yes, I want surgery, or yes, I want radiation, or you can follow the tumor and then maybe it shows growth or a new symptom pops up and then you say, now I want treatment. So it's either upfront treatment or wait and scan and then treatment. So we looked at those as subgroups, and the patients who underwent upfront treatment showed up in the office and said, I want column A or column B. 81% said they were happy with what they decided. However, the group that were observed and then elected treatment, 88% were happy with what they decided, so a higher number. And then once again, the group that has just been able to observe their tumor is the happiest, with 96% saying that they're happy with that. So it really brings up this question, and I don't really know if Albert Einstein said this, but it's a great quote. If I had an hour to solve a problem and my life depended on it, I would use the first 55 minutes determining the proper questions to ask. And that occurred to us. Maybe we're just not asking the right question.
So through our use of using the PAN-QOL for basically 10 years, the first thing is we've noticed that it's a lot better than the SF-36 and a lot better than all these other inventories. And so we're very, we're super happy that it was developed, but we also noticed a couple limitations in it. The first and probably the biggest thing is when you ask, if you study a large group of people and there's no differences between treatments significantly, the first question is it that the measure didn't detect it and there really is differences, meaning there actually are differences between the different treatment modalities. One is better than another, but we couldn't test it because the measure we used wasn't sensitive or good enough. That's one possibility. Or it could be the methods of our study weren't sufficiently good, they weren't ideal. Or it could be that there really is no difference on a population level between treatments. It has to be one of those three things. And so the question was, could we develop a different disease-specific measure that asks additional questions to try to get at these issues even better than the last one? And so in thinking about it, there were some overarching or recurring themes that would come up from members of the ANA saying, hey, that's a great survey, but you didn't ask me about this. This bothers me a lot, or this is important to me, but it's not mentioned anywhere. So through filling out the PAN-QOL, the other or previous instruments, we also had a comment box, and people could provide, they could say anything you wanted about things about the study, about things you wanted to improve, or just comments in general. And we looked back at this. We had several thousand comments that we've accumulated over the years, and we went back and read through them all again. As they come in, we read them. And then for the study, we went through them again, and we looked for recurring themes of items that were important to you that were not addressed in our initial questions. And we used those to construct a new questionnaire to try to get at other items that are important. And just for examples of things that are under evaluated or not addressed in the pan-qual, and certainly not the SF-36. Some of those examples were cognitive impairment, or some people feel like they are more mentally fatigued throughout the day because of their tumor than they were before having their tumor, or their reaction time or thought process is slowed in some way, or some level of forgetfulness or memory as a result of having their tumor. This is a classic example of us thinking it doesn't have anything to do with the tumor, but a lot of people saying it bothers them. And so, as surgeons or as clinicians, we say, well, the tumor is in the infratemporal space and it's not even in the brain. How could the tumor like that affect these other things? And so we would naturally say it has no effect on it, but we've heard enough people say that this is a problem for them that we have to listen to it. There has to be something there that we can't explain that's real. And so we included a full domain of questions that get at those sorts of issues. The pan-qual also only has one question on pain, although you saw previously that although pain is not a common condition with the diagnosis, if you have it, really can be problematic for you. And so we developed additional questions surrounding the concept of pain, just to get at that a little bit better. We also looked at unemployment or disability, the ability to continue with what you were doing before your treatment or before your diagnosis compared to after your treatment or after your diagnosis, which is globally a very good litmus for or barometer or measure of how you're doing in general. And so we added that, and there were other modifications to it too. So we went through several thousand questions. We went through hundreds of thousands of different data points, and through a process, we came up with a new quality of life inventory that we call the Vestibular Schwannoma Quality of Life Index. And this was supported through research support and also intellectual support from the Acoustic Neuroma Association. We had a patient representative who works a lot with the ANA, who is part of the ANA, Melanie Hutchins, who gave a lot of insight and feedback from what she hears from you, the members of the group. We all collectively came up with this new quality of life inventory. And so it's already been validated and used in English, for, of course, in English, that's how it was developed. But over time, we're working on developing in other languages. And really, our goal is to get at the heart of truth. We don't want to show that this is better than anything else. If we want to get at truth, and so we're going to compare this to the pan-qual over time, and it could be that both of these measures don't show differences in quality of life, which should be one step closer to us all realizing what we first saw, that the treatment has less bearing than other things we can do to help you or what you have to begin with. And so this is actually, we published it open access, so we paid an extra fee to allow it to be publicly available. So you can go online and you can type in the VSQOL space vestibular schwannoma or something like that. And one of the first links I would assume would come up would be this, and you can click on it. You can get the PDF for free that describes all of the different questions that are in there and the rationale for why we developed this and some of the things that we're trying to get out of it. So if you have time, I think it's an interesting read. And as always, we're the way it was built and how we are, we want to hear from you. We like engaging with you, and we'd like your feedback on it.
So really, I think where we're at now is there are very small and not clinically significant differences in patient-reported quality of life in patients with acoustic neuromas who undergo either observation, radiosurgery, or microsurgery for small to medium tumors. And it's the diagnosis that results in a decreased quality of life. So we understand that there are things affecting patients that significantly impact them on a day-to-day basis. And although we spend a lot of time in the office talking about risks of facial weakness and hearing loss, it's really dizziness, headache, and tinnitus that we need to be thinking more about. And most importantly, one treatment modality is not best for patients with any particular symptom. So patients who are very dizzy or have headache or tinnitus should not choose or avoid one particular treatment based on one particular symptom. And actually, patients are most satisfied if they have at least a period of observation before electing treatment. And that's especially applicable for a small tumor. So we hope our new quality of life instrument will better determine if there really are differences in the different treatment modalities, or might be better for one particular symptom or not. And we didn't show any data about this, but we're even thinking about how we grade facial nerve function, how we assess hearing. Maybe we need to rethink that as well.
So I know we went through a lot of different data and a lot of different points. And, one of the things that we feel and we hear from other people is when you're given more options and you get more data, it doesn't clarify things. It actually makes it sometimes it clarifies things, but sometimes it makes it more confusing because you have more information. So when you're diagnosed with something new, and particularly something like an acoustic neuroma or vestibular schwannoma, the first thing you want to do is gather data, and it actually is difficult to gather accurate or correct data. So that's one of the first challenges. But that's only half the battle, getting factual or useful data. The other half is swimming through that to understand which data applies to you and how you can use it to help your decision making. I hope that through this we've shown that there's not one treatment for a small to medium-sized tumor that is supremely better than others, but they each give you different things. And so what we always say, there are some people that walk into our office and say, I've looked at the information and I have a very sound decision. I know the information. We talk through it again, and they still feel steadfast in their decision to pursue a certain treatment. And that is great. Some people have that level of clarity. Other people become very analytical and like to look through the data and think through the data. What we always encourage in that situation is to take the 2 or 3 or 4 things that are most important to you and write them down. And then after that, really think about it and even get input from family members or friends who also know you pretty well and try to prioritize those 3 or 4 things. If you can take those 3 or 4 things and prioritize them, it'll probably lead you to the treatment that is probably most likely to give you the most reasonable outcome. And we always say, if you're unsure, if you have a small to medium-sized tumor, you should wait because the tumor's been there for many years to begin with, and most of them don't grow fast. And as long as it's small, in most cases, it's very low risk to wait a short period of time. You can never take a treatment back. Once you have it, you can never take it back. So make a good, sound decision that you own and you feel good with going into it. But we hope you've found this helpful. And a lot of the times I feel like when we present more data, we just make things more confusing, but hopefully we provided some level of clarity or at least new ways of thinking about some of these different concepts. And we're very grateful again for all your feedback and all of your input that have allowed us to do a lot of this research. So thank you.
Yeah, thank you very much. And we're happy to take any questions about this and any other aspects of vestibular schwannoma management.
Dr. Link, Dr. Carlson, thank you so much. That was terrific. It's interesting how we do have some patient questions going into this, and through your presentation, they get answered through there, but we do have a handful if we wanted to get into those. And again, we may have touched on some of these, but we had a patient with a medium-sized vestibular schwannoma where her symptoms, she reported manageable. Obviously, she wanted to maintain her quality of life. She's currently taking that observation approach. What would be, we hear this a lot from patients, what would be the trigger that would drive a treatment decision from there? What would you be looking for there?
We love that question because so many times people say, when do I need to have treatment? Yeah. The word need or required is very soft, and every person would define that differently. Historically, we would say when your tumor demonstrates growth that's detectable, and certainly sustained growth, we would, I think most people would say that's the time to pull the trigger. We kind of look at, we're learning over time that there's a lot of good data that says most tumors, so all tumors grew, no one's born with them, and it grew to be to the point that it is at the time of diagnosis. So by definition, everybody has a growing tumor. After diagnosis, there is pretty good data that if you follow them with a sensitive enough measure, most tumors have a propensity to grow over time. Still slow, but most have a trajectory towards growth. And so we think that probably just having growth by itself is kind of a nonsensical way to just say, okay, well, now you have growth, now you need treatment. Well, newsflash, it grew before. And so why didn't you have to have treatment right when it was discovered? So we kind of think size threshold is better. Like if your tumor starts to get into a certain range, that's really probably the best way to think about it. So like it's not perfectly defined well, and we're working on it still, but we think a size threshold of around 1.5 centimeters based on pretty good data is when your outcome, you have more of a slippery slope of having some of the less desirable outcomes from treatment if you get over that size. And so the The big thing is don't use that as a cut point. Use it as one additional piece of information in the whole decision-making process. So if you're, when the person said they had a medium-sized tumor, if their tumor was like 0.8 centimeters in the angle, if it grew a little bit, it's not going to change their outcome. But if they have a 2-centimeter tumor, it's probably reasonable to consider even treating it now, or if there is evidence of growth, because it's already a little bit larger. So the devil's in the details, but we kind of like to look in general more about size threshold than just absolutely looking at a little bit of size growth. But that's one of the things. There's so many factors that go into it. There's so many personal factors. Like sometimes people choose to have treatment because they have better insurance now and they're anticipating a change in insurance. Sometimes they can't have surgery at this time because they're caring for several young children and can't take time off. I mean, there's so many things that impact our decision making. But broadly, that's one way we think about it.
Sure. There's another question, and you had, Dr. Link, I think you had mentioned that you've seen a benefit to that observation time for a patient. Is there anything a patient can do during that observation time before, if they're anticipating, maybe eventually surgery or radiation, to help themselves have a better outcome? Is there anything they can be doing in the meantime?
There's nothing really too specific other than, of course, taking care of yourself. But probably there is some benefit to becoming very active, to getting your balance system tuned up. The balance system is one of those systems in the body that needs constant exercise or it will deteriorate quickly. I'm sure we've all at some point in our lives had the flu. Probably everyone's had COVID now. And, we were in bed for a week or something like that. And then you get up and start moving around and you feel weak and dizzy and off balance. And I mean, that's just from being sedentary. And so we always say to patients, boy, get out there and move. The best way to tune up your balance is to change where you are on the face of the earth under your own power. So walk, jog, bike, ice skate, downhill ski, jump rope, whatever you like to do those things, and that'll help keep your balance tuned up. And other than that, yeah, healthy diet, get plenty of sleep, the usual kinds of things we all should be doing, but probably don't.
Sure. Dr. Carlson, you had mentioned just at the end of the talk there, it relates to a patient question that we had where the patient was recently diagnosed, had met with a number of doctors, had so much information available to them with, again, you get a lot of different opinions, which is a good thing. But in this case, there was no clear-cut decision for the patient. Can you review again what you said, that would help them make those decisions?
Yeah, there's a couple ways to think about this, but the idea is that the more accurate information you have doesn't always make the decision more clear. It can be sometimes overwhelming because you have too many things, and really it comes down to your ability to prioritize that different information to find out what's most important to you. And so there's a couple ways to think about it, but sometimes there are some people that have a natural intuition after they've learned a limited data set that can naturally come to some conclusion, and then they get more information, they go back to their original decision. It's the gut feeling or that sort of thing, or that natural feeling. For a lot of people, that's pretty powerful, and that speaks to them, and they can actually have a successful decision based on that. But for a lot of people, you want to get more information, and then you have to understand how to prioritize it. There's a lot of things. So I'm going to give you examples of a couple statements that commonly heavily weight the person's decision, which I think is not good. So like one example is they'll hear something like radiation turns it into cancer. So the risk of that is about 1 in 2,000 or 1 in 4,000 for a non-NF2 patient. So for 95% of people with vestibular schwannomas who do not have NF2, if you get radiosurgery using a current dose, the risk is more rare than 1 in 2,000. The risk of having a very adverse outcome from surgery, like a blood clot or a PE or pneumonia or something else that can, I hate to say it, but take your life, is probably in that same order. So there's a very, very, very low risk of a very bad thing, even driving your car to the gas station. People I look at some of those things and they'll say, well, I don't want to have cancer, so I'm not going to have radiation. There are so many other more likely more common issues that you should really be prioritizing than that. So we always say, for example, that item, we say you should know it can happen, but it should not weight your decision-making at all because it's such a rare event. So you should look at the things that are most likely to happen and most likely up for an outcome and use those and see how they align with your goals. So a couple examples. If you don't know yet, or you think your symptoms are very mild and your tumor small, most people are best off just waiting and thinking about it. And if their tumor grows consistently, or they have more clarity over time with the information, you might enter a treatment, but you'll feel a lot better going into it. And during that time of observation, you can learn about the tumor. Like if it grew fast right away, you might be more inclined to have surgery, because there is some data that says fast-growing tumors better treated with surgery in that situation. So the first thing is, if you're unclear about things and you have a smaller tumor, particularly if you have low symptoms, minimal symptoms, or small, not a large number of symptoms, you should just observe. So I think that's the first thing to say. The second thing is, waiting a period of time allows you to get more data, have some resolution with it. So the worst time in a person's journey with a vestibular schwannoma on a population level is the day they're diagnosed. It's actually not, it's not the day after surgery. You would think naturally the day after surgery would be the worst because you have headache and you're dizzy. For most people, the worst day in their whole journey is the first day they were told they had a brain tumor. And that naturally creates all these different ideas and fears. And there is data that says the longer you sit on it and wait, the more peace you have with the diagnosis, knowing it's not an imminent life threat. So there is some data about that. But just having your, owning your decision-making process and going into it with good data is pretty important. So if you could so just getting back to it, like observation, there's no recovery time. Radiosurgery, there's no recovery time. But the effects are protracted over time. Surgery, you take all of it up front and you get done with it. So that's the benefit of surgery. So you have to look at what your goals are, and you have to look at what those different treatments give you and best align your goals with what the individual treatments give you. And I think that's the best chance for you to get the best outcome you can have.
Yeah, I think we can't emphasize enough that I think the best advice we can give to patients who are trying to decide what to do is, first of all, there's no, particularly with a small and medium-sized tumor, there's no wrong answer. It's not like we know what you should do and we're just going to see if you can guess right. Whatever you decide is going to be the right thing for you to do. And the main thing is try and prioritize. What do you really want to get out of the treatment? And if you can list 1, 2, and 3 in your priority, and then ask your doctor, will this treatment achieve that goal? I always make the analogy, I mean, this is a very big decision in somebody's life. It's like buying a house. Why did you buy the house you live in? Is it because of the school district? Is it because of the number of bedrooms? Is it because proximity to work? Was it the style of the house? Those kinds of things. So, nobody kind of gets everything they want in those big decisions. But if you can say, these are the 2 or 3 main things I want to get out, will this treatment likely give me those? I think you'll be happy.
That's helpful.
And paralleling that, in general, tinnitus, dizziness, and headache, don't decide on a treatment thinking that's going to necessarily get better with that treatment. Those are hard ones to predict.
Yes, I know we hear that a lot as well. So that's good information. Tell me again, how can patients with the new quality of life tool, is there a way for them to play a role going forward in that?
Yeah, so the most direct way and the way we prefer is if you go onto the Acoustic Neuroma website, there's an area under research and there's a link where you can find it. You could also email us directly and you can enroll in our study. But being involved in our prospective study is super valuable. Every single piece of information we had that we presented today from data was derived from a working relationship with the ANA and members contributing to it. And so we don't just say it to be nice, like it's impossible for us to do any of this without your contribution. So going to the website and finding it that way and following the link, we can get you signed up. It's a relatively painless process and you'll get automated messages to fill out quality of life data over time. Great.
Okay. Dr. Carlson, Dr. Link, thank you so much for working with us. Thank you for your collaboration and your expertise. We really do appreciate it, especially during ANAwareness Week. It's really helpful and you help us in so many ways. This is just, this webinar, the research, and so many other ways. We really do appreciate it. Thanks for being with us today.
Our pleasure.
Thank you.
Thanks.